In terms of Mr. Harris's experience from 2020 until now, he is the Special Advisor to Government of Barbados on the mortality reduction from acute coronary events in the country. He is also the Director of Medical Services, Queen Elizabeth Hospital from 2014 until now, an executive post with direct report to the Executive Chairman responsible for all medical matters and staff of the hospital and its satellites. That tenure has actually, yes. Mr. Harris was the head of the Department for the Cardiovascular Services, Queen Elizabeth Hospital from 2001 until 2014. Under that, he did cardiology and its subspecialties, cardiac surgery, pediatric cardiology, cardiac anesthesia as well. Mr. Harris has been a consultant cardiothoracic surgeon from 1993 until now. We thank you, sir, for your service. And he is the fellow in cardiothoracic surgery from North Shore University Hospital, New York, from 1991 to 1993. Yes, and it's indeed a pleasure to introduce Mr. Harris right now. Thank you.
Well, good evening. Thank you, Dr. Bryan, for your introduction. I think I now understand how women feel when you spill their ages out in public, but I'll forgive you since I supplied that information, trusting that you would use your discretion. But let me thank the Heart&Stroke Foundation. And over those 30 years of cardiovascular practice here in Barbados, I spent some of those years with the Heart&Stroke Foundation. So it's good to see you guys are still going strong. And I was particularly impressed with the medical reports of Dr. Scantlebury and Dr. Anne-Marie Cruikshank, who show that the Heart&Stroke Foundation is still very relevant, and of course it will continue to be so. And I was particularly pleased to recognize one person from the old days, Drew Simmons, and and to see that he is still going strong and still interested and still being given a service. Everybody else, I believe, here is young to the Heart&Stroke Foundation compared to what I would have known. And but I see that there is a Simmons Jr., so I guess it goes on. I got thrown into this sometime last week when I was asked if I could do the special feature. And my initial reaction was, well, it's kind of late. But I thought that, this is something that I feel that we should do, particularly of what is going on with something I know that you've probably heard about from Dr. Scantlebury, because she's been such a driver for it and things like that since she returned from the US. And that is how we are going to improve outcomes in cardiovascular emergencies, that is heart attacks. And I think that between her and the Caribbean Cardiac Society, of which I think you sit on that committee as well with them, they have been pushing very hard for us to pay attention to ensuring that people who do get heart attacks, that we improve the survival rate and take it down from what it is now in the high 20s % mortalities, and take it down to a first world level of under 10%. So that is basically the challenge. So I think you know what this is. This is your annual general meeting. And so, next slide, please. I told your team re-engineering and re-engaging 2023, reassessing our share in the advancement of care of all suffering cardiovascular disease, because I think that kind of says exactly what this program that I'm involved with at this time is all about. So, next slide. So the National Cardiology Product really has a simple goal: reduce death and morbidity from acute myocardial infarctions. As all of you would know, a person suffering a heart attack certainly is at risk of death, but even if they don't die, they can end up with serious morbidity and have prolonged course of limiting heart failure, and all of that is because of the death of heart muscle. And if we do not act on it promptly and quickly, those persons have that, their muscle die. But if we're able to act swiftly and with some alacrity, we can rescue quite a bit of muscle. And the quicker we are, the smaller amounts go. And in fact, I'm advised by Dr. Canterbury that if we can reopen and revise that within an hour, we can practically have no effect from that event. Next slide. So where are we now? I think we are at the point where we're almost having a heart attack a day in Barbados. And in fact, having said that, both of you your association takes care of that plus stroke, which is more than a stroke a day. And so it shows the importance that this NGO plays in ensuring that citizens understand, ensuring that people get involved with the teaching, the rescue, and the post-op or the post-event rehabilitation in what is, I heard someone says that cardiovascular events is close to the top of the morbidity rate. It is actually at the top of the morbidity and mortality rate for us in this country, and certainly in the first world. As we see here, we get these figures from the Barbados National Registry that we are, overall, we probably have close to 30% mortality rate, accounting for in-hospital and out-of-hospital mortality rate. But in-hospital mortality rate is still perhaps in the low 20s percent, still too high. And when we contrast that with the developing countries, who are somewhere 8 to 10% of patients who suffer a heart attack die, we see we have a way to go to reduce that down. And that's the goal that we have set ourselves over the next 5 years to achieve. Interestingly enough, I have that line there that has grabbed the attention of many a developed country, and that's is because of these awareness and stuff, because of these efforts to drive, because of the improving and measured quality improvements is how they get down there. They didn't just get down there because they wished it or because they had a lot of money. They really had to work very diligently to improve the outcomes. And I know Dawn has been a real champion. Dawn Canterbury has been a real champion of how we do this. She's always, so concerned that someone didn't get their ECG on time or they didn't get their thrombolytics on time. And certainly, I think just that consciousness has already, in my opinion, started to show fruit and started to turn things around. Next slide. Okay, it's always good to look back, and I think it was last year or sometime, I don't know if it was at your annual general meeting, but Dr. Ishmael had given a talk, and he basically had gone over the the history of cardiac care in Barbados. So I thought I would just briefly touch on it. We have starting back in 1971, and I'm doing this to show how it has evolved and why this is the next phase, the next frontier that we must tackle. Professor Trevor Hassel, who I think was your first president, started the cardiac unit at the Queen Elizabeth Hospital. In those days, it mainly addressed the issue of rheumatic heart disease. Ischemic heart disease was few and far between. And over the last 50 years then, that's 50, right? Yes. It evolved to care, the cardiac unit evolved to care for a lot of other cardiac conditions. And 1993, the cardiac catheterization lab was opened at Queen's Hospital. And all this just shows the evolving nature of cardiac disease in the country. And the opening of the cardiac catheterization really heralded and demonstrated that ischemic heart disease, the progenitor of acute myocardial infarction, is now our most common cardiac condition. Next slide. All right, and then, you know, we had the open heart surgery. Next slide, please. We had open heart surgery program in 1994. And with that, we were seeing that 70 to 80% of surgeries were for ischemic heart disease. Valvular heart disease has gone away from rheumatic heart disease for the most part, and is now in the older people of degenerative valvular disease. But the main condition that we are paying attention to is ischemic heart disease, coronary artery disease. And this really reflects the shift from infectious-based diseases, rheumatic heart disease, that would have been a plague in Barbados in the 50s and 60s, and disease patterns are now driven by the NCDs. If we were to be as successful with ischemic heart disease as the Professor Hassel was with dealing with rheumatic heart disease, it would be a very good thing. So we will keep our fingers crossed. Next slide, please. And throughout the region, the Caribbean region, there's a similar story, a similar pattern. In the smaller islands, there's still rheumatic heart disease being a problem for them, but for the most part, and certainly in the larger Caribbean islands of Jamaica, Trinidad, Bahamas, and Guyana, it's a similar story, all developing open heart surgery programs. And I have there, because I think it's important, and it shows where the stress was placed, that the Queen Elizabeth Hospital recruited an interventional cardiologist, Dr. Don Scantlebury. And notice, Don, I was very kind. I didn't put the date we recruited you. So we're on to the next frontier. So we responded to the 2020's challenges. In 2019, the Caribbean Cardiac Society recognized that mortality, next slide please, mortality from acute myocardial infarction remained high across the region. We in Barbados knew this because, I think you remember, Drew, around 2007, we actually developed in Barbados a Barbados National Registry to look specifically at the numbers and outcomes of acute myocardial infarction, strokes, and cancer. And that was certainly a visionary move because it certainly provided us with lots of data, and we were able to properly track accurately what's going on with those conditions. Also in 2019, a special committee, I think which Don, as I said, was part of the Caribbean Cardiac Society, had met with the Caribbean heads of government and point out, basically, we need to take care of this. We need to put strategies in place that can now help us deal with the scourge of death and morbidity in acute myocardial infarction and bring those numbers down. Next slide. And I have there 2019, but it's actually 2020. The government, to its credit, established a desk and a mandate to decrease morbidity and mortality from heart attack in Barbados, and I was asked to sit at that desk. So the first thing was to develop an agenda of how we were going to deal with it. And I think we started basically, next slide. We had to review the manpower needs at the hospital. The hospital still is the central place that most, if not all, acute myocardial infarctions go. So we had to look and see what we needed to do. We review and revise data collected by the BNR. What we revised was not so much the actual data, but we revised the data points that we thought we needed to follow more closely to ensure that we are getting good results. We looked at the ambulance service, the EAS, the emergency ambulance service, and ensured that they're who going to transport the patient to the hospital had the resources and equipment that they would require, human resources and equipment. Since in the 90s, we have seen in Barbados the rise of a number of urgent care centers, starting with FMH, and a number of them have come up. I think there are now 5 or 6 of them. And we felt that, and our data was telling us that 30% of Barbadians who get chest pain and believe they're having a heart attack actually went to the urgent care centers. So we knew it was important that they become part of the network on the chain of survival, or whatever you want to call it, but that we had to ensure that they were our allies. So we looked at all of this. We knew that we wanted to be sure that everyone was doing the same thing. So Don laboriously developed the protocols and the algorithms for how to manage a heart attack, all in trying to ensure that no matter where you go in Barbados, that you get the same standard and level of care. We took advantage of the redesign of the A&E. As you know, there was the accident and emergency, had a multi-dollar revision of its facility, and we wanted to be sure that we had space in there for what we call a chest pain unit, or some place where these people can be treated promptly and so forth. Now, that is still in the works because the accident and emergency is not yet fully expanded, and but the vision still is there, and we have your Anne-Marie Cruikshank, who is also the new head of Department of the Accident and Emergency, who will ensure that there is a because she can't be the officer for your cardiac emergency care and not take care of it at our hospital. So we expect that we will have those facilities and things in place. Even without that, I think there has been a sensitization for finding space to quickly take care of these people in the accident emergency, even if they don't call it a coronary unit or chest pain unit. So I think we have seen, in my impression, some improvement. I know Dr. Scantlebury is never happy unless things are absolutely perfect, so she's not yet fully happy, but she's getting there. And we also needed to know what the public really knew about cardiac emergencies. So we hired Professor Devnish from the University of the West Indies to do a survey study to find out exactly that, not just what they knew, but who knew it, what age groups knew it, and exactly where were the misconceptions and stuff. And he produced a 25-page document for us, and I did share this with the Heart&Stroke Foundation because I thought it was important. As the chief NGO for cardiac conditions, you must be our ally, and you must play a part in getting this out to the public and stuff too. And around that, we have started to design a comprehensive program for public awareness. We have had a strategy committee who looked at it. The Heart&Stroke Foundation was represented on that committee. And now we are into the implementation phase, and I have once again sent out invite to the Heart&Stroke Foundation through its executives to join us in this, and I think you're going to be you have to be our ally for us. In my way of looking at it, I think you are the link between the medical professionals at the hospital, certainly, and the public of Barbados. And if we are going to succeed in getting the message out, getting the public well educated about cardiovascular disease, in my mind, I see a major role for the Heart&Stroke Foundation, and that's not just because you invited me to talk here. I honestly believe that. And I think that, I know that we have had some discussions with Dr. Cruikshank, and we had looked at how the pilot that they had done for the schools, and I believe that that is a strategy that we have been convinced is one that we should take, and try to continue to reach out to the school leavers, both at primary and secondary school leavers, to ensure that the generations to come have a clear understanding of cardiac emergency and how to react in that emergency. So I was particularly excited to hear the large number of training of individuals who were trained in cardiac emergency, both in Barbados and beyond. But certainly I was for you to be doing 2,000 in a year, that is really special, and I think you should be applauded for that. Of course, then we also felt that we needed to get legislation to protect the public, because we wanted to be sure that the public is comfortable after they've been trained by you, that if they do see someone who do arrest, there is no hesitancy based on worrying about whether they are legally protected or so forth. And this Good Samaritan legislation, which says a person who have had some exposure, some training, and then participated in a bona fide cardiac emergency will be protected from suit should anything go wrong. So ribs get broken sometime, and people don't recover or don't always succeed. So, you don't have to worry then that you're suddenly trying to help, you're legally exposed. And also the other thing that we are looking at, of course, is the whole deployment of automatic external defibrillators in the public domain. These are very useful devices and really should be at all major gatherings, particularly sporting events, party events, where people can drop down and can have trouble. We know that they're in some stores in Bridgetown, they're in some residences on the West Coast. So we wanted to be sure that there was proper regulation governing those things and ensuring that they would work. Okay, next slide, please. So, I have here that on October 14th, 2022, the Queen of Hospitals signed a memorandum of understanding with 4 urgent care centers, providing them with that's a thrombolytic drug to use on the hospital's behalf prior to transport, so that we are really looking at cutting down time. This is a strategy that I know that Dr. Canterbury has been advocating, and we were able to get this enacted and make sure that we are able to deliver to you a drug that can open your artery if you were to go to an urgent care center, rather than have to be transported to the hospital. You wait for an ambulance, you get transported, you do some more wait in the accident and emergency, particularly since our data was telling us that could potentially add upwards of 2 hours to the presentation. So we wanted to be sure that by the time you get to the hospital, you have already had your medication and you are on your way, your treatment has already started. And I think this was that was a very novel and really out-of-the-box way of approaching it and stuff like that. So it's not necessarily any like great invention of a thing, certainly in the United States, who have far more greater distances to go than we do. Their ambulance and ambulance personnel can deliver that drug. But we know that that in Barbados, the furthest point is about half hour from the hospital, with sirens and stuff. So we didn't think it necessary to go that far, but we certainly think it was important that we have the urgent care centers participating. And the urgent care centers are not just the private urgent care centers. If you recall, in 2018, with the change of government, one of the things that was promised in the manifesto of the BLP was that there was going to be a 24-hour service at Sir Winston Scott and the David Thompson complex, essentially turning them into urgent care centers for the public. And I certainly felt that this was an important move, and that it had the potential of just expanding it for everyone. We might argue that the Lady Mead, the Sir Winston Scott Polyclinic right next to the hospital may not have that great an advantage or that great an effect, but certainly the David Thompson in St. John did, and it really, I think, has a great role to play in this whole cardiac emergency stuff. What have we achieved with all of this? We looked, as I said earlier, we have looked at the resources that was required. Now, you know that we never get government to approve anything that calls for a lot of expenditure, particularly when it comes to staffing. But we use this WISN, which is, what's WISN the acronym for again? Right, Workplace Indicator of Staffing Needs. And this was the first time we were using it at the hospital. In fact, it was the last time we used it at the hospital as well. But what it is a tool that is provided by the World Health Organization that really it don't just guesstimate what someone think you need. It really does go about trying to measure the amount of work that needs to be done and needs to be covered. And we use that. And it was a very scientific approach. And I would like to think that because we did it that way and presented a paper to Cabinet, we were shocked to some extent that they improved as much as they did. They didn't quite improve all, but they improved a significant amount, probably 70 to 80% of the request, which was a huge step. Now the ball is in the hospital court, because all of that also talked about cardiologist posts, technologist posts, all the posts that we have found difficult in the past to fill. in any timely fashion. But at least we have the posts to do so, and we have now to come up with a strategy of how we're going to fill those posts effectively, and we have started, and we have gotten some nurses. Part of the recruitment of nurses from Ghana and stuff was focused and all of that with providing nurses for our various areas and departments. So now, as I said here, we are now challenged to recruit the staff, and I hope that we can be as successful. Next slide. Emergency ambulance enhancement. We know that we need to increase the manpower. We even have vacant posts in the emergency ambulance service, but I think we have been sensitized to, and has sensitized the political directorate that we do need to increase the number of ambulances and ambulance crews to match them. And they have responded, I think, with some encouragement. They have also given us the commitment to restart training at the BCC for the emergency medical technicians and the paramedics. The emergency medical technicians are your ambulance officers who have a lower level of training, but forms part of the crew. And what we're hoping is that every crew, 2 or 3 man crew, will have at least one paramedic who are the higher trained. I think there's a 2-year training course for them, right? It's 2 or 18 months. But the emergency medical technicians are just trained for 6 months. We have done and have gone through the training in identifying and managing cardiac emergencies for the emergency ambulance service. Dr. Bayer has been certainly pushing this, and in fact, he has going to be retraining some of these crew after 2 years. So that is going on well. Improved technology for the department, which I will show you soon. And that technology provides transmission of patient data from the field to the hospital so that the hospital can be well prepared before that person hits the doors of the accident and emergency. I would like to get to a point where we encourage all Barbadians not to put their loved ones or whoever, their neighbors and stuff in, or try to drive themselves down to the accident and emergency, because we know that a number of people do present to the accident and emergency dead on arrival. What kills you in these heart attacks is the arrhythmia that you develop, and certainly you can't resuscitate someone. The layperson are not going to resuscitate that one in the backseat of their car and stuff. But to get here, we have to be sure that the public trusts that there will be quick response by the ambulance and that they could depend on that. If they could depend on that, I think a lot of people can be persuaded not to snatch and run, which could be dangerous for them. And there is an increased number of ambulances. It has been estimated that for a country this size, we need to have 12 ambulances to service, and we are now at 10 because they have acquired 3 ambulances within the last year, and its 11th one is on the way, and hopefully we will be able to get that 12th one as well. But we have to match the ambulances with the ambulance crews. So we have to, work in conjunction with that. So we are looking good, we are moving in the right direction, and I hope that maybe in the very short future, we would have it right up there, and with a sophisticated dispatch system that Barbadians can be convinced and trust that their ambulance service is responsive, and that you read the newspapers and it's hilarious, and who is the cartoon character Adolphus? who try to suggest, you wait for days for an ambulance, that we can that we can get our ambulance, that Barbados would understand that all ambulances will get to them within 20 minutes and get them to the hospital in time. That is our dream, and I hope that it will come. Next slide, please. These are just some of these equipment that we were able to purchase through this program. Was able to purchase for the ambulance service. The monitors there are what I talked about that can transmit the data via the internet. And this thing at the bottom is called an autopulse, which I will show you how that works. Can you play the slide? Can you play the video for me, please? And actually, the ambulances of Barbados now can be equipped with that. They have that. That's Dr. Byers' toys, and he is quite happy with that. And okay, this is all very nice looking accident and emergency, and I think you will be happy to hear that Dr. Bushank is doing a great job ensuring that it works well, and I think we should all thank her for that. I really think it is something that is not easy to achieve. But I think we recognize that within recent weeks, there has been a little fight on the scene. So we have this, and it is going to be a further study very shortly. So all of that will refine the facility for cardiac care, I hope. And I think we can look forward to a better service for cardiac emergencies at the Smith Hospital
I think that the two ladies that you have in your organization have been fully responsible for that, and that they will, I'm sure, will continue to keep fighting. And no one dares cross their paths. I'm sure that they will get through. And lastly, this is just the report produced by Professor Dwayne Devonish. As I said, it's a comprehensive report telling us where the deficiencies are, and basically has formed the backbone of the strategy for how we are going to tackle the the public awareness, and to be sure that we get the message out there properly. On this strategy committee, we have a guy from the UK, the National Health Service, which I don't know if any of you remember. Because he gave a talk to the Heart&Stroke Foundation a number of years ago, Dr. Cliff Bucknell. And Dr. Cliff Bucknell has come to give us advice, but perhaps the biggest piece of advice that he's given us is that things like these take a while, and you can't be impatient about them. It's not something that you say you implement and then 1 month later you are going to see results. It's going to have to be a much more, we have to demonstrate far greater patience than that, and be prepared for the long haul. So we're going with that advice in mind. We are now starting the implementation of the public awareness program. And we are, so over the next month or two, you should start seeing jingles, because we have to cater to the young people, print media, articles within the newspapers, televisions, things like that, all targeted to get things going. But we are going to, strangely enough and paradoxically enough, be targeting the younger folk more. Because if we get through to them, all the old folk like myself is be listening out for that, right? So we don't have to be told or prompted to listen out, but if we can get to the younger folks, we will have planted a seed for the future. So thank you all very much for thanks for inviting me. I hope I lived up to your expectations. And I trust that you found this useful. And I don't know if are you going to force me to take questions? 5 questions?
Or 5 minutes, Chuck comes first.
Okay.
I want to thank Mr. Harris for what was not only just educational, but an indication of the intersection of what that project is seeking to do and where the Heart&Stroke Foundation lies within that national plan, so that we fully understand the importance of what we do and the necessity to maintain and to strengthen in conjunction with. And it's also quite instructive that both Dr. Scandersbury and Cruikshank are directly involved. So I won't say we have exciting information, we just have a good lead into what is necessary, and that we need to ensure that we're able to assist in reducing that morbidity. So at this time, I'm hoping that there are 1 or 2 questions for Mr. Harris, but I want to thank him for agreeing at a short notice to come and speak to us. So thank you very much for that as well. Wait to see if there are any questions. Do you have a comment? Sure. Where's my comment?
Harvey, I just want to thank you for a very interesting
We were, the last time I was on council, you were there with me.
excellent presentation. There is a program on CBC TV now on Wednesday nights that I am very proud of, with Crystal Hoyt in the know. It is so good. It is so good. And I think this information that you've shared with us can benefit from a program that because it's not only young people, it's the older folk like us who need to know what it is going on. And maybe we can engage with CBC and have a do a program in the know.
Agreed. Something to look at. But also I think as well to see how what we're doing on the promotional side for Eugene, for example, might intersect with what
Yes.
with that program, and to expand that because it's directly aimed at young people. In a way, to I'm sorry that Professor John has left. One, to make it mobile. Two, to make it more accessible. Because in some instances, people can't necessarily afford to come to us. We need to actually go and meet them where they are. And I think that's critical, especially for prevention.
Thanks, Mr. Harris, for speaking on what we've been doing at QH for a while. I actually wrote a little note in my book to remember to ask or to make a comment. You had spoken of the transition from the infectious diseases, rheumatic heart disease, and to ischemic heart disease. I think you kind of answered what I was going to make my comment on at the end. When Professor Hassel introduced the cardiac unit to speak to rheumatic heart diseases, he was able to be almost completely successful at most managing rheumatic heart disease. First of all, I was a patient with rheumatic valve, but it was so rare. And my colleagues in Egypt and Sudan and whatever are still speaking of heart disease, but also has been eradicated. But the problem with ischemic heart disease is that it's not just a matter of making sure that we know our training and to recognize the rheumatic fever and to treat it appropriately is a lifestyle societal problem. And it's going to take a long time to knock it down. The first one hasn't yet, so it's going to be with us for a long while, which is why stroke is so important at looking at the all levels of prevention for cardiovascular disease. That was number one. Number two was that I did not realize that it was 1971, so we allowed 15 years of the cardiac unit to kind of slide by us. That because it would be 2021. And that kind of yeah.
Long time.
No, but I mean, we should have made it fast. That's a landmark. We should have.
Yeah.
done something.
It's never too late to make a fuss. You can blame COVID and celebrate 50. No, I'm being serious about it. Sure. Right. There being no more questions at this time. I want to thank Mr. Harris for his presentation. And I dare say we will be calling on you again sometime in the future. Can't think of it right now, but we will be. But thank you so much.
Okay, thank you. I do have to run on.
Okay, no problem. But thank you. And it's at this stage that I will turn proceedings over to the chairman